Orthostatic hypotension, also known as postural hypotension, refers to an atypical drop in blood pressure when a person stands up after having been seated or lying down. When standing, gravity pulls blood down away from the brain, causing arterial pressure to drop. Ordinarily, this drop is transient, lasting only through a few cardiac cycles. If an individual lacks the necessary circulatory reflexes or blood volume upon standing, lesser amounts of blood and oxygen will reach the brain. This is manifested by dizziness or syncope and increases the patient's risk for falls. The baroreceptor reflex normally kicks in to compensate for standing. Baroreceptors located in the vessels of the chest and carotid sense a decrease in blood pressure that will lead to an increase in vasoconstriction and an increase in heart rate to bring blood pressure back up. In the longer term, levels of epinephrine and antidiuretic hormone increase in the blood to also help maintain blood pressure while standing. There are varying causes for orthostatic hypotension. Hypovolemia, or reduced volume in the vascular compartment, is one of them. Blood pressure may be sufficient when a person is sitting or lying down, but when they stand up, they get lightheaded. Some common causes for hypovolemia may include inadequate fluid intake, excessive urination, use of diuretics, excessive sweating, loss of fluids from vomiting or diarrhea, and loss of fluid that occurs from prolonged bed rest. Heart conditions such as heart attack, heart failure, and bradycardia also decrease the cardiac output that is necessary to overcome the pull of blood away from the brain when standing up. Endocrine issues like hypothyroidism or low levels of cortisol, such as with Addison's disease, can lower blood volume and blood pressure, putting a patient at risk for postural hypotension. Diabetes can damage neurons, important in the negative feedback loop for increasing blood pressure when standing. Many medications have the side effect of postural hypotension and increase the risk for patient falls. Meds used for hypertension and angina fall into this category, including alpha blockers, nitrates, ACE inhibitors, ARBs, calcium channel blockers, and beta blockers. Other drugs that may cause orthostatic hypotension include drugs used for erectile dysfunction, like sildenafil, sedative or anti-anxiety drugs like benzodiazepines, hypnotic drugs like zolpidem or diphenhydramine, muscle relaxers such as cyclobenzaprine, tricyclic antidepressants or TCAs used for depression or nerve pain, dopaminergic agents used for Parkinson's disease such as levodopa, both atypical and typical antipsychotics, anticholinergics like oxybutynin, opiates like morphine, and cardiac glycoside digoxin used for heart failure or atrial fibrillation. Alcohol, the most commonly used CNS depressant, also increases the risk for orthostatic hypotension since it causes vasodilation. Orthostatic hypotension becomes more of a problem with increasing age. This is due to decreased activity of compensatory mechanisms like the baroreceptor reflex. Elderly persons also have reduced blood volume and reduced skeletal pump function, which further complicates the problem. After age 70, patients are more likely to experience postural hypotension due to the aging process, and this is the most often systolic dysfunction, which causes a decrease in blood flow to the brain. Elderly patients also are more prone to be taking antihypertensive medications or diuretics, which further compounds the problem. In addition to dizziness, patients may experience weakness and ataxia, which may include abnormalities in gait and speech. It's important to treat and prevent orthostatic hypotension, especially in the elderly, because fluctuations in blood pressure to the brain increases the risk for stroke and complications from cardiovascular disease, like angina, heart failure, and arrhythmias. Having healthy skeletal muscle pumps helps blood return to the heart to increase preload, to help prevent orthostatic hypotension. Being immobile and confined to a bed brings about changes that beget postural hypotension. Immobile patients have reduced plasma volume and decreased muscle tone in